morning, everyone, and welcome to the Health and Adult Social Care Scrutiny panel. Before we start, do we have any apologies? Okay. Could we move on to the
It is on.
The system should pick it up. Sorry about that.
Yeah, should be good.
Okay, any apologies? None. We move on to the minutes of the previous meeting, which was held on Tuesday the 18th of June. Any matters arising from the minutes?
Yeah. I can see that we requested a written report with an update on the impact of the investment to reduce wheelchair waiting times and the outcome of what's gone on with tendering for the wheelchair service.
We'll follow that through. That has been sent. We just haven't received anything yet, but I'll make sure that's followed up.
Is there any, and the next item is interest, any councillors which will willing to declare an interest on any items of the agenda?
Linky Day, I'd just like to declare an interest relating to the transforming of outpatient care, because there has been some Health Watch involvement with that, and I am a Health Watch volunteer.
Thank you for that. Any members of the public?
That's fine.
Okay. Deputations or petitions?
None received.
So we move on to the item West Yorkshire and Harrogate Local Maternity Network. We have officers who will present that report to us.
Thank you, Chair. My name is Karen Poole. I'm the Programme Director for West Yorkshire and Harrogate Care Partnership, and I'll let my colleagues introduce themselves.
I'm Cathy Munro, Public Health Manager for Kirklees Council.
And good morning, I'm Helen Sevens, I'm Service Director for Integrated Commissioning for the Council and the 2 clinical commissioning groups and for the CCGs. Okay. Can you hear me now? Can you hear me now?
Okay, from a maternity perspective. So, in support of NHS England's National Maternity Review in 2016, which identified a number of areas, and I'm sure you all heard about the tragedies of Morecambe Bay, and that set off the review, and there was investigations across the country working with women, working with professionals, and they found a number of areas that we needed to work on to make sure that services were, in the first instance, much safer than they have been in the past, more personalised, kinder. We needed to offer women real choice and for them to be a partner within their care as well. And I don't mean a care plan that's just a tick box exercise, but something that they're really embedded, they feel they're in charge of, and they can make those choices with really good evidence that professionals are presenting to them. In response to that review, they asked that we set up a local maternity system. And in the main, those local maternity systems fit with the STPs across the country. And there were 44 of those, there are now 43. So West Yorkshire did that on the footprint. We were one of the biggest in the country. I think we're the second biggest LMS in our country. So the population that we're serving is 2.5 million. On good days, I'm delighted to work in such a big area, and other days I think I wish we just had 2 providers and we could move forward. But there are real opportunities for being a really big system. We were really fortunate in 2018. We'd started our work, but we were fortunate that we went to the West Yorkshire and Harrogate Care Partnership and talked to them about the maternity service and about this way we needed to work, and they actually invited us to be one of their priority programmes. For me as a maternity commissioner, that was absolutely fabulous, that maternity was really high on people's agenda and they were really supporting this way of working, and we could really give quality services to women. So we had a stakeholder group, we developed a board, and that's grown and grown over the last couple of years. We also had staff and women at the centre of everything we did. Engagement was really important to us. We didn't want to design services on our own. It was really important that we didn't. But we also needed to take staff along that journey with us and embracing them and taking forward. That's a huge amount of staff. That's 6 acute providers in a lot of hospitals. But we wanted to embrace them. It's not just about hospital care either, it's that wider element. It was really important that we involved everybody. And if I think of GPs as a really good example, they felt very much pushed away from maternity services. They're part of the family, they're part of taking this lady through her pregnancy, but also looking after that family afterwards, and also that preconceptual element as well. So our stakeholder list is huge, and we've got really good engagement. I think the important thing, an early decision that the board made, that we needed to look at prevention as well as part of our programme, because actually what we knew is that women are often arriving and booking in, and actually they may be obese, they're smoking, and at 10 weeks that's quite late to be starting to make an impact. So a big element was we must ensure that prevention is part of this. The big important thing is there's a lot of shared learning as well. What some trusts are doing, how people are really making progress and others aren't, was really important to us. So a big element of this is about that sharing element and taking away variation. But that choice element as well. So if I work in Leeds, but I actually live in Kirklees, I can have all my antenatal care if I like in Leeds, but I can deliver in Huddersfield. So it's really important that we've got systems in place to be able to make sure that's safe and that the women know about those choices and that the staff actually offer those choices as well. Because we know in areas we've got great choice sometimes, but women don't always know about those choices and they just go down one route. So it was really important that we looked at that work. And we looked at culture, because as I've said, safety is really important. If you look at litigation and the cases that have happened against maternity, it's the biggest area that we pay payouts in the NHS. It is maternity services, by a long way. And please don't think I'm just talking about money, because it's quality of those families. But that impact is for everybody where we're making errors, because that mum can't work, it affects the economic well-being of the family, but also it affects all our services where we've got disabled children going through those services. So we have to be safer. Absolutely, it's paramount that we need to do that. So what we did was, with our staff and with the Maternity Voices Network, we call that Maternity Voices, which is a group of women who work with us to establish the work we needed to do. We had a robust plan. Apologies for that if anyone wants to look. It was about 100 pages. But we wanted everyone to understand that, be engaged in it, so it's very, very clear about what we were doing. And staff helped us develop that. The women and their families also signed that off and engaged and challenged us. We were seen as an example of good practice, so we were really proud of that. And also it's helped bring some money in as well, that we had a good plan. Our vision is here. It was, as I say, it's service user owned, and those visions are there. It's about place where people want to go. It's about partners getting and families getting the best quality care information, preconceptual guidance. We actually know that postnatal care isn't that good, and we need to look at that across both midwifery, GP and health visitors, and it's probably one of the places that we get the biggest complaints, so we also needed to develop that better. We also have a challenge about something called continuity of carer, and that's where a woman receives continuity. It doesn't have to be a one-to-one midwife. It will be a midwife, perhaps a team of 4 or 6 midwives, giving care to one woman. What we know from that, from the research, is it's actually 30% safer to deliver continuity of carer. So we have challenging targets, and we didn't meet those targets last year. Across the system, they needed to be 20%, and we were at 11.7%. But we had plans in place to be able to do that. We felt that we did a really good job, and we engaged staff in it. It's very different. If I'm a midwife, I've worked out in the community for the last 20 years, and I'm really good at my job, but I've not been doing the interpartum, the delivery stage. And you're now saying to me, I want you to work different shifts and I want you to deliver this baby in an acute setting. It's very different. So we need to train people, change the mindset and bring them on. So we didn't meet the challenge, but actually I feel that we were doing a really good job. You can read for yourself that we want to be quality service. We're not responsible for neonatal care. That's actually what we call the neonatal ODN and specialist commissioning. But we need to work better together to make sure that we get the right outcomes. A really good example of that is if a baby under 27 weeks gestation is not born in a neonatal unit, a big central neonatal unit, we know that the outcomes are not as good. So we're really driving to ensure that we get those babies into the right place at the right time, if that makes sense to you. So we're very closely working with neonates, and we're just waiting a publication for a neonatal review. But we will work closely. We've got really strong relationships with them. I've talked to you about choice, and choice is really important, really important. You can see those overarching outcomes there. We need to look at perinatal mental health, and we're working with a mental health team to ensure that we get really, really good perinatal mental health. I think the important thing is there's been a lot of developments for the women at the higher end that are needing really specialist care, but we want to look at that very early end about promoting good emotional health and well-being, identifying earlier and actually getting women into services early. That's really, really important to us. So again, that's work that we're undertaking, and it's very important to us. From a safety point of view, we have a challenge. We have to reduce stillbirths, neonatal deaths, maternal deaths, babies that are having bleeds in their head because they've had a difficult delivery. Within the next 5 years, we have to halve those. As you know, and I don't need to tell you, we lived in some quite deprived areas, and some of our numbers are quite high. We really need to put that prevention element in to ensure that we're doing that. So, some of the things that we've done to date. It was important that we undertook a needs assessment, because actually I've come from Kirklees and I understood the needs of Kirklees, but actually we needed to understand that patch, the whole patch. We also did an equality impact assessment to make sure that we're working with those hard to reach communities and ensuring that we do that. And that can be a challenge, but we are certainly looking at addressing that. I've talked about choice and personalisation. We're developing care plans. We have a booklet that women have compiled that's called My Journey. Takes them all through everything that will happen to them. You can go on a website and you can give you a choice. You can put in, this is my 3rd delivery, I want this, this and this, and it can tell you the places that you might want to book. Please don't think that takes away professional discussion, but it's a really good starter for people to be able to look at. We have our Maternity Voices Network, which is all 6 areas have got maternity voices, and that's women coming together and sharing what they're doing in their area and spreading that good practice. We've started to look at workforce. Workforce in all areas of health is really challenging, and we do struggle with recruitment. So we are looking at joint recruitment across the whole patch for newly qualified midwives, which will stop people going for 3 interviews and then choosing one of them And I'm expecting that midwife that's chosen somewhere else. So we're looking at that. Leadership is a real issue for us, and we've looked at how many leadership courses the midwives have been on, and we know there's a gap. So we're looking at what leadership opportunities that we can get for them. And we're also looking at something called preceptorship, which is when you first qualify for the first 12 to 18 months, you're given support. We're all doing it differently across the patch. We're going to do that the same, and it be a really robust methodology. That will help us with retainment, we know that, and it will stop people moving around the system. Eventually, I'd like to tell you that we'll have staff moving around the system. We're not there yet, but those might be early discussions, certainly where we might have gaps, but also that opportunity for learning as well is really important to us. So we've done some financial modelling, and we will be sharing some of that across each area, how people can perhaps cut some of the costs. There might be some cost-saving exercises for people to be able to look at. I've told you about the continuity, and we've got so many plans and supporting to help trust with that. Communication and engagement is absolutely essential to us. We're such a big area that we've got a robust plan to be able to do that as well. Prevention I've talked about, so we've got 9 prevention groups that Cathy will talk to you about in a minute that are sharing best practice. That's not saying you're not doing something right in Kirklees, but it might be, actually, what else is happening in Leeds that Kirklees can take on board? How are you managing to get I'm making these numbers up, but how are you doing so well with smoking? What are you doing differently? So we're looking at the evidence and we're sharing those best practices. We're also got NICE involved in that, which is great to have that NICE guidance as well. So our work continues. One of the things that we are now really moving forward is the ethos of community hubs. So community hubs, and people call them maternity hubs, and I don't say maternity hubs because there are so many hub developments across areas. So we've got the new primary care networks, we've got Sure Start, we've got children's hubs. They name them all differently across the 6 areas. The important thing is that we get away from the terminology, but it's the ethos of what we want to create is somewhere where women out in the community can access services that is right for that community. So that might mean in one area that you've got a GP involved, you might have I'm sure you'd have your health visitors involved, but actually how would social care like to be involved in these concepts? So there isn't a blueprint that says we need to do this. It's starting to work together to look at those communities and develop that ethos. And for that reason, and we're working with Kirklees anyway, but that's one of the main pieces of work that Cathy and myself are moving forward on. I'll let Cathy talk to you now about the Kirklees element.
Okay, so as I said, I'm Cathy Monroe. I work in public health, but I'm also supporting the CCGs around the commissioning of maternity services. Our involvement with the LMS has been going on for a while now, and I would say that we are, as a place, Kirklees, fully embedded within the ways of working with the LMS. The 2 senior responsible officers within the LMS are actually both from Kirklees. So we have that kind of senior level downwards. But just to kind of take a step back to give you a bit of a broader context about the work that we're involved in with Kirklees, we've had a focus around antenatal care, preconception and the very early years for a number... Sorry, can you hear me? For a number of years now. Focusing on what's called the 1001 Days Agenda, which takes you from conception to the age of 2, which is really about ensuring that children have got the best start in life, which feeds very much into that shared outcome that we have across Kirklees. The work that we've been involved with, which we've kind of put under the banner of Nurturing Parents and more recently established a Best Start strategic partnership group to oversee that, is actually broader than the 1001 days. We take a starting point as preconception. So as Karen mentioned, that point around people being healthy and fit before they actually become pregnant is really crucial. So that's kind of our starting point. And actually with our work, we go through until kind of school age. And this work with the LMS and the focus on kind of antenatal and preconception is really crucial to all of that. As Karen's mentioned, we have 2 well-established Maternity Voices partnerships within Kirklees, one covering the North Kirklees patch, the other a joint one with Calderdale and Huddersfield, both of which work very closely with maternity services in the area, the 0 to 19 practitioners, local women and service users, and they're a really effective and strong partnership, and we work together to understand what the experiences are of women and try and work with the services to develop things. And that all feeds into the LMS work as well. As Karen mentioned, prevention is a really crucial element of the work, and I personally sit on the LMS Prevention Steering Group. So that involves representatives from public health teams across each of the areas within the LMS. And within that group, we've identified a number of priority areas, probably things that you would expect really. So around smoking in pregnancy, breastfeeding, physical activity, alcohol and substance misuse, consanguinity, parenting and attachment and bonding, that kind of relationship building, screening and immunisations, and reproductive health. So we're in the process at the moment of starting work with a number of expert groups. So there's an expert group linked to each one of those priority areas, which pulls together kind of key people from across the LMS patch, looks at the evidence in relation to each of those issues, and we'll be pulling together a plan with recommendations that can be implemented at place, but also some things that can be implemented at scale across the LMS. And we've just had the first one of those groups, which is around parenting and attachment, which was really well attended and went really positively. As Karen mentioned, our priorities really going forward at the moment are around I must admit, in my element of the paper, I have referred to them as maternity hubs, so I consider myself slapped. But we are working really closely with our colleagues across Kirklees that are involved in all the other hubs that are kind of out there. So we're having discussions with people that are involved in the community hubs work, so the kind of the school-based side of things, the primary care networks, the work that's going on around the review of the Children's Centre core offer, and trying to kind of look at what we've already got within Kirklees and make best use of our resources in a way that's going to work best for women and families. So we've an initial kind of Kirklees-wide meeting that's planned for next month, where we'll do some kind of general scoping around that with a view to actually then looking at what's going to work best and how we can move things forward. So I think from conversations that I'm already having, it feels like it's a really positive a positive move in the right time, because there is so much kind of development going on, and it feels like it's the right time to actually incorporate the maternity elements and that support for women and families, and make sure that we've got the preconception work embedded within that. I think that's probably it from me, from a kind of a public health and prevention perspective.
Thank you for that information and detailed sort of presentation. Before I put it out to questions, the maternity voices that you've mentioned, is that officer-led, or is that the mums to be expected mums?
We have two slightly different models. So the Maternity Voices Partnership that works across, that's the joint one across Calderdale and Huddersfield, is completely service user led. The chair and all the kind of secretarial support are provided by mums. The North Kirklees one is actually supported through Anti-PAMS. So the project coordinator with Anti-PAMS provides some of the admin support elements, but it's still attended by service users as well. So it's just kind of two different approaches, but both actively involving women. And as a positive move, our Calderdale and Huddersfield meeting has actually started to get some dads attending it as well, which I think is a real positive.
Thank you. Question?
Hello, I'm Councillor Alison Monroe. I just want to ask you a question, first of all, in relation to the community hubs, actually. So I just want to know how you envisage these will work. Do you see one in every ward, for example, or do you see one per primary care network? Will there be staff with professional people, paid workers, or are you expecting volunteers to work there and help run them? I'd just like to know more about how you envisage they're going to work, what their aims will be, what their role will be in our communities. Thank you.
I think at this point in time, a lot of it is still up to be shaped through those kind of conversations with kind of services and service users. I think because within Better Births there wasn't it wasn't really prescriptive in terms of what it had to look like. It's about kind of meeting local need. And I think in my head I can imagine a scenario where there might well be kind of like a hub and spoke model almost, in that there might be main centres and then smaller centres, because if there's an expectation that certain elements will have kind of maternity or obstetric care, it's about being realistic about what the trusts can actually staff. But equally we would want some of that broader, you know, the kind of the preconception support, things around stop smoking, weight management, those kinds of things being a broader offer that was available more routinely within communities. So I think it's potentially around you know, linking in with the existing kind of hub structures as well, and about ensuring things are embedded within those as well, rather than it just being a separate standalone thing, if that makes sense. But I think a lot of it is going to come down to the discussions with partners about as well around what they think will work.
Right, I'm concerned because, you know, in some areas we don't have these hubs as such yet. So, I mean, are you know, are they going to be placed in public buildings within our local areas, or how, you know, I'm just concerned, and are they going to be staffed by volunteers, or?
I think every hub will probably look different, that you'll look at your locality, design that with women and put the services in that you need to put in. I would hope absolutely that the voluntary sector will be part of that. Particularly we use the breastfeeding coordinators, the cafes, absolutely I would do that. But I do think that each area needs to look and design what services they need in there. So an example is, I'm working with Harrogate tomorrow. Harrogate smoking is really, really good. They're smoking, and perhaps they wouldn't need a smoking support in there. But actually, if we look in areas around Dewsbury or in Wakefield, where it's really, really high over in North Kirklees End, isn't it, that we would think about looking at the smoking services that needed to be there as well. So I do think it's very much about looking at the areas, working with the women. We don't want to set up a service that women don't want either, so they do need to co-design, but to look at that community and look what's required.
Okay, thank you. So I'm afraid I just have a further question. So, is the onus going to be upon volunteers running the social aspects of these hubs? And if that's the case, how are you going to engage volunteers to run this side of the hub?
We need to go out to the various groups and start to engage and identify them by doing a stakeholder analysis. So in the West Yorkshire and Harrogate Care Partnership, we've got a volunteers group, someone who leads that would be able to identify those people and look at taking that work forward with those. But as I said, they are in very, very early development. And actually in Kirklees, you're probably one of the ones who's moving more at pace to look at this. But it is really important that time is spent to look at them. And we have delayed some of this. For one of the reasons there are primary care networks setting up, and there's so many services setting up in some of my other areas. We've got closure of some of the children's centre ethoses, so setting them up, and they were then closing down. And we just feel now it's so important. But Cathy has identified many stakeholders, and the work needs to start now with those needs and looking at driving that forward.
Okay, all right, thank you. So, but the onus isn't going to be upon volunteers running those services?
No.
I'd just like to follow on from that discussion. In terms of these community hubs, what sustainability strategy have you got in place? Because you know, when you're relying on the same services going into different communities, you put in a drain on those resources, and you know, with the current climate, we don't have enough staff to go into communities. So when you're talking about community hubs, how many are you talking about setting up, and particularly in North Kirklees, with the level of issues mums face? Can you give us an explanation on that, please?
Again, we haven't thought about the numbers. I am being absolutely honest. We have a small amount of transformation money now to set these up, and it is a small amount when it's across 6 areas. So we need to look at building this within sustainable services that we've got. Absolutely. But sometimes we're duplicating. How often do we hear that the midwife comes in and then the health visitor goes in? Oh my goodness, we don't need to be doing that. We need to look about the competency of the staff, and we just need to be really pragmatic and look at how we deliver the services. So what I would say to you is, there's 25,000 for each area. It's not for each area. So for Kirklees, you get 25,000. We can't use that money to think it's sustainable money. It's about working differently.
So who's currently looking at that? You know, we're talking about this service, you know, being delivered, but, you know, do you have somebody who's going to oversee that and ensure there's no duplication and ensure, you know, the services are effective and it's being monitored and we're getting the outcomes that we're looking for and it's having the right impact on those mums? And, you know, in one of the other services, you've said you've not met the targets for last year, the continuity carers. So how are you going to ensure that you are meeting the targets for this service?
In terms of the work around the hubs, that's, like we've said, we're at the very, very start of the journey in Kirklees, but it's my priority kind of piece of work. So, you know, those kind of concerns are, you know, I'm hearing them and I'm noting them, and that will be something that you know, will obviously be a key element of the work as it develops. What I'm really keen to do, and which is why I'm having some of these conversations prior to this initial kind of broader stakeholder meeting that we've got, you know, is getting an understanding of the position that we are in at the moment in terms of where the primary care networks are at and what their priorities are, how they're working, what position the community hubs in terms of the works with schools, where that's at, how they can feed into this, the work that's going on around reviewing the Children's Centre's core offer, and looking at actually what can we do jointly, what can actually be embedded within those existing systems of working, so that actually all of this kind of information, so that we're not repeating or duplicating things, but so that, and it's not necessarily about having to have a separate, you know, a separate maternity hub, as it were, within each area. It's about making sure that the things that are in each area already are right and are giving out the right information, and there's that consistency and quality in terms of information from preconception onwards. And it may be that then, you know, in terms of the maternity element, or, you know, what can realistically be done in terms of maybe some of the more clinical elements, you know, that might be in one or two areas, perhaps. I don't know. This is just me thinking off the top of my head, so please don't quote me on this as we go forward. But do you know what I mean? I think for me, that's what I was saying about potentially, you know, more of a hub and spoke model. I'm meaning more around actually all of those existing hubs or networks that are out there, making sure that they're all fully engaged and understand and are engaging with families and are giving out the right information and are able to support people. And if they don't have things in there that we know that those communities need, for example, stop smoking support in some of the areas where we've got our highest smoking and pregnancy rates, making sure that that is in place, making sure that they, you know, that they understand the importance of information and advice being available preconceptually, postnatally for subsequent pregnancies, and all of that kind of thing. So, you know, we are at the very, very start of this journey, and I think that's the positive thing about coming here now, is that we can actually involve you in shaping kind of what that looks like, because we don't have a blueprint, we don't have a set plan that we have to follow. It's within our gift to develop that for Kirklees.
Thanks. Yeah, I'm interested in the what the nature of your budget is. Are you going to be the budget holder for maternity services across the partnership? And just to point out, you did say you had nothing to do with neonatal services, but it says in 522 that one of your key aims is to ensure financially sustainable maternity and neonatal services. So that seems slightly contradictory.
We're not responding. Oh, sorry. So I don't hold the budget for all of maternity services. At this moment in time, the monies that I hold is a transformation pot. And in our first couple of years, we got 150,000 to deliver the whole programme, year 1 and year 2. In year 3, we got 500,000, and I did moan a little bit about the size of the service that we needed to cover. And this year it was a bit of a hallelujah moment because we got 1.7 million. So we were really delighted to be able to get that money. That money is just for transformation. Quite a lot of that has gone out to providers to be able to help them to deliver some of this continuity. We know that where we've put a project person in to support them with this delivery, it's worked well. So we've done that again this year. We've given them money for equipment because actually you've got midwives working in a different way and there's a lot of money needed to go out for equipment. We have also put some money into the prevention element. So as the prevention groups move forward, they'll have money to spend on consanguinity, what they need, etc. for that. We will get some more money next year. I don't know what that it will be. I suspect it might be similar. And then that will be it. But one of the things that we are looking at, and it's in very early discussions, is how do we commission maternity services moving forward into the future? And would that be the responsibility of the West Yorkshire In Care Partnership? We don't know. It's very early discussions. The central team, like that we're talking about that, we've already written a specification to ensure that services are commissioned the same, because that's really important if we're sharing. But at this moment in time, we don't know. I think what you've said about the sustainability of the neonatal services, midwifery helps with that sustainability. If we're getting those babies in the right places at birth and they're getting the right care, then that helps those services to be sustainable. That's the ethos that we've taken from that.
So,
Thank you. Do you have
yeah, so just to be clear, this 150,000 that you've had this year has, sorry, 1.7 million, that has involved a finance director undertaking financial mapping. That's not to do with the provision in the future overall of maternity services. That's just the expenditure of this pot. And you don't know who in the end will manage the budget, then that's still under discussion. Yeah.
To next year, that will go.
That'll be it, finished.
That will be it. Yeah.
Can I bring Peter in?
Thank you. Just to clarify, Karen, so when the transformation money goes, the CCG will take over, or the trust will take over to sustain the developments?
There might be a small pot of transformation money after next year, but it will not be to the size that it is now. Maybe for a project person like myself, but that will be it, yeah.
It just seems a pity that the thing will need to be maintained. And
I think the important thing is, and we've spent a lot of time building a system of drawing people together, the heads of midwifery, the clinicians, people at the trust, people out there. And I think what we're doing is, we will build and build on that. But as we withdraw and the money withdraws, we can do that in a planned way.
Alan, would it be useful if you told us a bit about how the maternity services are commissioned for clarity for the panel, please?
Currently, each area, each CCG, or sometimes this is shared, they have a maternity commissioner who will commission that service. The service specifications across the area have been in place quite a number of years, so they all actually needed changing, but most areas do have a maternity commissioner. Often that's just not their role, being fair. Often they do maternity and children's and other elements, but that's how it's currently commissioned by each CCG. There are some elements that will sit under specialist commissioning, which are some fetal medicine specialist, or if the women go to intensive care, then that would go to a different budget at that stage. Or say she's got a renal problem, that might come out of a renal budget and be commissioned by somebody else. But the basic maternity care is commissioned by each CCG locally. The neonatal care is commissioned by specialist commissioning.
Thank you. Did you have a follow-up question, Peter?
three things really first, and I'd like to come back to consanguinity before we end, but the more important things, probably, or the more prominent things, are the issues of choice, that of quality, and most crucial, outcomes. If I could take them briefly one at a time. We've heard a lot when it comes to choice during the last 20 years, you know, about empowering women, personalised care plans and so on. What's happened to it all? Because we still seem to be saying the same things, and I do congratulate you. I mean, this report is like motherhood and apple pie, which is what it's supposed to be. But you know, it's very attractive. But what's been happening? Has it all been hot air?
Can I take choice first? So I agree that choice has been going on for a number of years. And in Kirklees, we're really fortunate, aren't we? We have, sorry, I came from Kirklees, so we have the best choice, I think, across the country. Absolutely, we've got a really good choice, but do we always offer women choice in the right way? So some of the things that we've been doing, and this is taking a step back, and you might think it wasn't required, is we've done some staff training about how they talk to women about choice and how they deliver that. Now, we start with the midwives. We need to take the obstetricians through some of this as well. But it's really important that we continue to work with staff to how they have those really fruitful conversations to women. But also that we advertise the choice as well. So we've got an area in our LMS, and they have done remarkably well when you look at the surveys to how they are offering choice. I don't know, that's might be because they haven't got a lot of choice. I don't know if it's like when you're buying a car, you know, if you've got loads, what car do you buy? So I think sometimes when you have a lot of choice, it can make it difficult, but we really need to get better at that. As I say, we've got the website there, but we need professionals to keep continuing to discuss choice. And choice every time the woman comes in, because it changes. Women's perceptions, what they think about, how their care is. You know, they might get some medical advice that it's different. We've got to keep offering choice. We've got some fabulous films that we share with people where we've got some women that, and actually it was a Huddersfield case, and she really did feel that she got offered choice, and we've got to do more of that.
But at the end of the day, I mean, we've got to face facts. Choice is in conflict with safety. And at the end of the day, if this has to be medicalised, or if and often at the end of the day, we've got to accept that the midwife knows best.
Absolutely. And always we sometimes need to make medical interventions, but we need to tell people why. And actually they'll still feel they've got a choice. So the film that I'm talking about is about a lady, and she was offered the opportunity to carry on with a normal delivery, but she might need interventions. But actually medically, they felt that she needed a caesarean section. And she talks about making a decision and then going home and ringing them and saying, can I change my mind? I've actually thought about the medical advice you've given. But always safety has to come first. But that's about meaningful conversations, isn't it, and doing it right.
Just to go to quality, I think you cleared up, Karen, the difference between continuity of care and continuity of carer. They seem to be used interchangeably. And my assumption when I read it was continuity of care is about record keeping, continuity of care is about personnel, and you've said. But just to take that a step further, I just wondered, and you did touch on this, you don't say much about diversity in there. And I just because it's fine if you're a middle class woman living in Home Firth.
I absolutely agree. And the important element for me is with continuity. At first, I think we were just looking at some of our numbers to start looking at different models and how it might work. The long-term plan says that we need to look at diversity, and actually they're going to measure us on our BME community receiving continuity. I'm really keen that we don't widen the gap from inequalities. Absolutely. And as these models progress, we have to keep ensuring that we're working in the right areas to offer continuity.
And how will you measure success?
We will measure success in various ways. So we're doing evaluation on the continuity models that we're trialling in places. We also have what we now call a maternity service data set, where the midwives put all the information into their system. It's submitted to the national team, and they will be able to pick up exactly who's had continuity. Because the women, it's a new guidance, is this, the women will need to go onto a continuity of care pathway by the time they are 29 weeks. That's a new rule, it wasn't before. Because what they're saying is, really, get these women early, get them that you're engaging with them and they know the midwife. But absolutely, we are evaluating what we're doing, and it is a measure. I'm held to account by the continuity of carer figures on a monthly basis. I have to say as well, this is probably one of the most, the programme, I've never been as clear about what we need to deliver on and the outcomes that we need to achieve and be measured on as I have this maternity programme. It's not easy to deliver, but it's very easy to know what we're doing, and you've seen the trajectories on the back. It really is. It's very clear what we need to do.
Can I just last one, please? And that's outcomes in relation to safety. And I wondered who was going to set the outcomes, what they would be, and how they relate to the National Maternity and Perinatal Audit, which was published last week, and how you're going to hold trusts accountable. The audit is very clear. With criteria of postpartum hemorrhage, second and third and fourth degree tears, and APGARs of less than 7 at 5 minutes. So, we have a safety forum that's really important to us, where we share all the information. And I think in the past, trusts have really been good at looking at their incidents, but actually that's within that trust. The important element for us is that learning, that they use those tools, but that learning is across our system, and they bring them back into the safety forum, and we learn from those incidents. Our safety outcomes are the ones I actually talked about reducing the stillbirths, reducing the, absolutely, those are measures that were in there. Yeah, but there are other things like magnesium sulfate, which is called Precept on this report. It's really important that you give that drug. It's a drug that you can give a woman up to about 30 weeks of pregnancy, and it really does stop children getting disabilities. But we're only giving it to 79% of women generally across the system. We've got that up now. We're really pushing on that to make sure that we get that higher. We won't get it to 100% because some women on some days will just arrive and they will have their baby very early. But those are really important measures. The other measures are things like giving them steroids before their preterm birth. Again, I think it's on all my measures here. They really are strong, and we are pushing each other. It's great that people are bringing their evidence in and to be able to share it across that system of how they're making a difference. And with regards to the present state of affairs and where you intend to get, presumably that's covered in the tables as well.
All our trajectories are set over the next 5 years. We do need to just change perhaps some of the numbers because our populations are changing quite considerably, actually. So we've seen Harrogate and Airedale and Calderdale and Huddersfield have a bit of quite a reduction in their births, but then we've seen Mid-Yorkshire have quite an increase, and Leeds as well. So the numbers that are there were predicted on the birth when we started, but we will change them. But they're all predicted, they're all very clear. We have a performance dashboard as well that we are challenged by our board, and service users are really sat on the board as well, so they're keen to look at that performance as well as we are.
Thank you for that, Peter. Can we move to David? Sorry, you've been waiting.
Yeah, I've got a question on the Appendix 1, the trajectories on page 17 of our report. The bottom 4 items, I assume trajectories means targets, basically. Is that right? The trajectories targets? Are they targets, effectively? Yeah. Yeah, so the question is that those 4 at the bottom of the page, they look very ambitious. So your starting point on the one on the left is 10%, you're up to aiming to get up to 100% within a couple of years. The next one 0% to 95%, the next one 50% to 90%, and the final one 20% to 51%. So they look very challenging trajectories.
I like to be challenged.
Yeah,
but-
it's how
but-
realistic it
but-
is to achieve those.
What I would say to you is these are national targets that we have to deliver on. And absolutely they're very challenging, they're very difficult, we need to achieve them. If we're going to achieve the outcomes that we need to do, then we need to do personalised care. And I think once we get a system, by the way, we're all on different maternity electronic systems, which doesn't make it easy. But once we get onto a system, we can perhaps get an electronic patient record on there, as well as paper. I know that not everybody likes electronic. We know that our women want paper as well. But we do think that once we move forward, and that's part of practice, such as the care plans, we can do that. We can do those elements. The personalised care element, that women report that, we've got to do it. They are challenging. And it's what I expected of us.
I accept that. You did mention previously one of the targets which you haven't been able to meet so far over the last 12 months. So already it's clear that it is difficult to meet targets. So they may well be challenging, but if they can't be met, how realistic is it to keep to those target figures?
The national team want to see those targets. We have challenged them. So if I take the continuity of carer target, which is the one that we've not met, as I say, we've got very robust plans. The north of England, we actually did the best in the country to reach those targets. Our LMS, we were sort of in the middle of the people in the north. We first worked as a board to look at these targets, and we set a target of 10%. We thought that was really good, working with all the professionals and the women. And a month later, we had a national directive that it would be 20%. We knew that was a challenge for us. We put things on the risk register and everywhere. It's on every risk register there is going. Our element is that we will remain safe. We will not change practice if we're not safe, and we will strive to meet these targets, and we're doing okay. But it's slow, but we're taking people with us. But that target has to remain there. That had to be submitted to NHS England, and those challenges that I have set on numerous occasions and had those discussions. But I think we're working really hard to those. The other targets, I think the stillbirth stuff, we did really well. We've done really well over a number of years. Getting to the next step will be hard, but I really believe that we can push and really go towards those. If you ask me about the main ones, is that continuity, but I cannot not have that target in there.
Just related really, on page 15, 5.3.1, you mentioned a number of risks that are rated red. Just wonder what sort of mitigation is being put in place in relation to those red risks.
Keeping people engaged. We were all enthusiastic at first, and we're having our ups and downs. We are visible, we are out there, we report to chief execs, we get them on board so the message can keep being relayed to people and ensure that we continue to embed that. We're doing roadshows out in trusts, local authorities, and we feel that we've been really proactive. We have got a strong engagement strategy and comm strategy. That's really important to us. So we're really working hard to ensure that we do that, and we're very visible out there in those areas. And I think our ethos right from the start has been engage staff and let them build these models and do the work. We'll continue to do that. From a perspective of recruitment and retention, that's really difficult. We know across the health sector that it's problematic. As I say, we spoke to you about leadership, we've talked to you about the preceptorship programme that we're doing, but we're also working with the local area workforce board to ensure that we look at recruitment generally, because that's really important. It's not just about the midwives and other things. We've noted there paediatricians is an issue, and that's being looked at in one of the other programmes. That impacts greatly on maternity services. You can't have any level neonatal unit if you've not got paediatricians around. So it's something that we need to look at. But the Royal Colleges are all involved in a lot of this work. But it's really hard. But you know, one of the things that we're really working about is that retention, working with staff about those change models, because one of our visions is that we will be the place that people want to work. It's hard. But that's what we're doing to address that. And the continuity of carer elements, as I say, we've got project people in each trust now looking at that continuity. We're really driving people forward. I've got a nurse in the team specialising on the continuity, and we'll really push people forward.
Can I just ask you, in terms of the roadshows that you've been doing, I've not heard of any sort of engagement in the communities. Can you tell us where you've been doing them?
They're actually going to be out in the trust to begin with because they're for the staff.
So you've not actually...
Yep, they're starting November. The main ones are about that staff engagement. So we need to make sure that staff are engaged, and that's what those roadshows are mainly about.
The way you portrayed it is like, well, we're really proud of this engagement, as though you'd already...
No, sorry. We're proud of the engagement strategy that we've got and how we've engaged people to date, but we need to carry on to do that.
Okay, do you want to...
Oh, hi. Leslie Warren, I'm a new councillor. Yeah, I mean, there's a lot of new jargon which I'm trying to process. And it's clear that, you know, you're all under a lot of pressure to deliver with limited resources. My question really was to do with the maternity hub, which is like another layer of hubs. I've just been involved in the recently formed community hub where we live in Slough. It's a small amount of money. Are you setting yourself up to... It becomes more a tick box exercise than one that will actually be effective, because you've obviously got a limited budget. You sound like you're going to have to rely on volunteers a lot, or at least volunteers are going to be part of it. And volunteers are in demand absolutely everywhere. And the public perception, as we know, is that our NHS is badly scrapped, is slowly being privatised, and that in 20 years' time it won't exist. Now, OK, that's not the point of this question. The question is this going to be realistic, that a community hub with a small amount, maternity hub, the small amount of money that you're going to have is actually worth doing rather than working with existing hubs?
But I think that's... Sorry, too keen on my button there. I think that's, you know, that's kind of the approach that we're trying to look at is to try and work with those existing hubs, systems, networks, all the other things that are out there about embedding this kind of work within them, which is part of the work that we were on with anyway, as part of the kind of the nurturing parents and best start kind of work that's been ongoing around trying to ensure that everybody that has contact with children and families has that same knowledge and understanding about the things that make a difference to children having the best start in life. And this, to me, is kind of an added layer to that, really, about building in a more robust system in terms of ensuring that preconception advice and support is embedded within our communities. To my mind, that doesn't have to be a specific separate maternity hub, and in some ways labelling it as such is a limiting factor, I think, in my opinion. I think it's about getting that stuff out there to everybody.
Just ask, I mean, I understand, thanks for that. Can I ask, are the whole idea of hubs like a CLEAS initiative initially, or is it a government-led initiative?
The maternity hubs bit comes directly from Better Birth, so it was one of the recommendations within that from 2016.
Okay, thank you.
Just going back to the questions we talked about, challenges earlier on. The continuity of care, how are you measuring it and how it's going to work out? I still am not very, very clear, and I'm going to go on to something very personal, but whilst in a GP surgery, maternity clinics were happening and another part of the centre, and the women there were complaining, and I overheard the conversation. It was nothing to do with that, but it was a case of we've had more than one maternity change, more than one midwife. We don't know what's happening. The My Journey booklet sounds really, really good. I wished, we had it a long time ago. It's still in very early stages, and I don't think a lot of the service users are able to adapt to it, not let alone the midwives and everybody else who's doing that. So can you tell me a little bit more? So sorry about the fact that we're having to repeat that bit.
The continuity won't be a one-to-one midwife because you just can't deliver that. It will be a small team of midwife, but the women will feel that it's really that continuity, that the team know her well. There's that discussion. We will measure, it will be measured via the midwives going into the system, documenting their notes, and their name will be against their qualification number, and the national team will be able to see exactly where a woman's had that continuity. So if there've been more than 4 midwives, then they will be questioning that. Now this year that's not happened, being fair. This year it's been a paper exercise. Last year it was a paper exercise. This year it's a paper exercise, but the year after it will be extremely robust and they will be able to get it off the system. I think that's really important, that we'll know exactly where we'll be delivering that.
Sorry.
The MSDN that I'm talking about, where they submit all their electronic data, is actually working now, and they're doing some tests already. They're just not that sure that by this year it will be robust enough to do that. So I am assured. I think the other thing is, even the paper exercise, I'm absolutely assured that the paper exercise that we have done has been really robust. So I know in other areas they've perhaps put people onto pathways where they've added up Decembers. We had to give people going on a pathway in March. That was our measure, just of March. And I know some areas have perhaps counted January and February and March as their data. We didn't do that. I absolutely know the data that we're reporting is robust, and I know it's right. So it mightn't be that high, but it's robust data, and we absolutely delivered that. But as I say, in the other years, it will be very robust.
Thank you for that. Just for clarification as well, can I find out why in the other 2 sections where you've given number of births and projected figures for, you used 2015 as a baseline for both stillbirths and the other one. However, in brain injuries, it was used as 2016. Do you have the numbers for 15? And
it depends on what your data sources are. So some of the data things are at different times, because you might use the ONS data, or there might be a data that mightn't come out for a year or 2, some of the data. So it is a little bit all over, but that's because of where the data is. But 2000 for the stillbirths, 2015 was where the national team wanted you to start to count. So I do apologise that it looks a bit odd, but it's just that mechanism being of where you can get that data. Some of it's really quite difficult. It only comes out yearly.
thank you. It was just for clarity, just to make sure that
Yeah.
I understood what was
Yeah.
doing. Thank you.
Hello, just a final question from me. This is in relation to the draft local maternity system service specification that's been drawn up by commissioners. I just wonder if you could tell me a bit about it in terms of, has it been tested? Will we be able to see it? How do we know it's going to be fit for purpose? Those kind of things. If you could just give me some information about it, thank you.
The specification that's been developed has been developed by the commissioners. Providers have been involved in that, and actually it's based on a national one. So about 2 years ago, a national specification came out. It needed changing because there are new continuity of care is different, saving babies' lives is different, so it just needed an update. So generally, that specification is based on the national one. We do expect with the specifications that there will be some slight differences to some of them. So if you look at Harrogate and you looked at Kirklees, how they commission and other services such as their health visitors and how they work together might be a little bit different. So we do expect there will be some localism, some bits of localism to them to make them work, if that makes sense to you, because services are a little bit different. But it is based on that, on the national specification. Some of them in the past have been huge, they're massive specs. This is very much an outcome spec that was developed. But I'm quite happy for that specification to be shared. Kathy's got that, and we're happy for that to be shared with people.
Thanks. If I could just come back on the prevention and the preconceptual, and you mentioned consanguinity, and I just wondered what initiatives you were
we are right, I feel like a broken record now, but we have the first meeting of our consanguinity expert group tomorrow morning in Bradford. So I'm co-chairing that group, so my expectation is that we will share the learning and our experiences from the work that we've done in Kirklees previously. So, you know, the work that we've done over the last 10 years or so around women of childbearing age and all of that kind of thing, that we'll feed that in, but that we'll also be learning from the other areas. There's also been some research, quite a large study done at Sheffield, was it, recently? So we've got the information from there, although they're obviously outside of our LMS area, they're sharing that learning with us. So it'll be a case really of pulling all of that kind of shared learning, the most up-to-date evidence base and things together, and pulling that into kind of a set of recommendations, really. So we're kind of at the watch this space, really, but we kind of hope to have a set of recommendations out by the end of, well, we've got 12 months for that group, so within that time frame.
The question was obviously premature, you know, and you're now to deal with that. What will be the constituents of the group that meets?
It's a mix of public health, hospital trust representatives. So we've got maternity and obstetric or paediatrician. NICE are involved in that group as well, I believe. Genetics, yes.
Sorry, that's what
Yeah.
I think just to note as well that the service users are involved in that. So the service users have told us what they want to be involved in. They've looked at the plan, they've picked out areas. Sometimes they'll sit on some of the working groups and they'll be the voice, and they'll go back to their big group and bring that back. Or with some things they'll say to us, just bring us the information. So they're choosing their ways of involvement with the different groups.
Am I okay?
You are okay, but we're conscious of time.
Right. Yeah, just to ask, you've just mentioned service users being involved on the consanguinity group. Also, there's quite a lot about maternity voices, women's participation in the Maternity Voices Partnership. I'm just interested in how these have been recruited and typically what the retention is of users as opposed to providers or commissioners.
Different groups in different places, I would say. Some of them are very well established. They've got a lot of members and they've been there quite a long time. But that's really good for us because some of them are new. So if I take Airedale and Harrogate, they're very new. But actually that's the big thing about having the network. They're sharing how they're taking their work forward and how they've developed over time.
And it's also not just about the women and their partners or whoever that physically come to the meetings as well. So the both groups also have kind of active Facebook pages or different kind of ways of engaging with women, and they also run kind of quite regular surveys around different either specific issues or, for example, the Calderdale and Huddersfield group has a kind of an ongoing maternity experiences survey. The North Kirklees group has relatively recently run a survey around birth trauma and women's experiences of that. So, you know, in terms of faces that come to the meeting, it's normally, you know, the same kind of people. We do get new members in, but that kind of wider network that they're engaged with is large.
I think importantly, we're not representative of the community, the people that attend the meetings. We've done an equality impact, we're very aware of this, and we're looking at how we recruit other people. So we are very aware, and it's important that we progress with that work to make sure that we are representative.
Thank you for that. So in terms of the next steps, if we can allow the overview and scrutiny panel for health and social care to take into account the information that's been presented before us. One of the recommendations that I've got for you is ensure that there's a sustainability strategy that's in place, monitoring the impact and outcomes of the service, and you're not duplicating and repeating the work that's been delivered, and ensure that diversity is acknowledged within all your services that have been delivered, with the relevant impact on those services, and engage the different communities as and when necessary. Is there any further recommendations anyone would like to suggest?
Yeah, Under developments to date, it says financial modelling has commenced. I think it would be good at some stage to see the financial model.
Thank you for that, and thank you for your presentation and attending the meeting. We will move on to the next item. The next item on the agenda is Transforming Outpatient Care at Calderdale and Huddersfield NHS Foundation Trust. And we have officers to present that report to us. If I could invite you to next start.
Good morning. My name's Lisa Williams. I'm Assistant Director of Transformation and Partnerships at Calderdale and Huddersfield Foundation Trust, and I'm the Programme Lead for Transforming Outpatient Care. My colleague?
Hi, I'm Debbie Graham. I head up Partnerships and Integration, representing the commissioners. The commissioners in both Calderdale and Great Huddersfield work as a single team into this programme. So I'm representing that team, although my day job is in Calderdale.
Okay, if we could just move on. So thank you for inviting us back to present and give an update on our outpatient transformation programme. Panel members who were present when we came last year will recall that we presented our strategy for how we were approaching transforming outpatient care across Calderdale and Huddersfield, and this morning we'd like to give you an update. You have a paper in your packs, but we've also prepared a presentation which I'll just quickly go through. So just to recap for new panel members, CHFT has always run a traditional outpatient programme that's had multiple handoffs, multiple appointments for patients going along one pathway, which can be quite confusing and quite time consuming from referral to diagnosis and treatment. Just to give you a few statistics, in 2017-18, when we started this project, we had seen physically in our outpatient department over 350,000 outpatient attendances. That's not patients, that's attendances, so there will be multiple attendances per patient. Healthwatch in 2017 did a survey of 500 patients across West Yorkshire, and an overwhelming 95% of patients said that they would like to see outpatient care delivered in an alternative way and given a range of options that worked with their lives rather than around an organisation. Our staff, our colleagues at the Trust and within primary care have told us that things could be done differently, and if we could transform our pathways, that they could focus their time where it's really needed, which may be in theatres, it may be reducing waiting lists, it may be spending more time on the ward areas. Earlier this year, the long-term plan came out that supports the work that we are doing, which nationally, there is an aim to reduce outpatient attendances, physical face-to-face outpatient attendances, by a third during the duration of the next 5 years. So we looked at this, we started our work around April 2017, and the case for change was quite simple really. We looked at what our patients had told us, that they were getting less than an optimum experience, and in quite often a poor experience. They were doing multiple visits, some unnecessary visits. We traditionally bring patients back to outpatients to tell them that they're absolutely fine. And for some people, this is a real inconvenience for their lives. They're sat waiting, struggle to park, it's a cost to patients. And when they get here, there may be clinics that are overrun, and they may have actually had to take time off work, find childcare, and if they're self-employed, that's been quite costly to them. We've had a growing demand over the last few years in outpatient referrals from primary care. Some of this is through NICE guidance for new conditions. Some is just a trend in different disease progression and follow-up appointments. Our waiting times subsequently have increased, and in some of our key specialties, we have seen vacancies that we haven't been able to fill. And some of that is down to the actual models that we're delivering. And doctors, it's not an attractive option to new doctors coming out qualified that don't want to work in a traditional system. When we looked at our face-to-face appointments, 99% of our outpatient appointments were delivered face-to-face. So over the last year, we've engaged with as many people and as many groups as possible. We've spoken to health and wellbeing boards, we've done scrutiny panels on both sides, we've spoken to other providers, such as Locala, our community providers, the CCG, South West Yorkshire Mental Health Trust, private providers, and up and down the country we've been linked with other areas to see what they're doing and what we can learn and share. We did a wide engagement with our clinical colleagues to see what they thought. They're the people that have the answers. The patients and the clinicians have the answers. There's no textbook approach to this. So we've opted for a very much a bottom-up approach and listening to what people want and how they want that delivered. We went to any clinical audit day that we could with our colleagues. We found them in dining rooms, corridors, business meetings, MDTs, in their offices, the dining room. Everywhere we could to have a clinical conversation about what was best to be done. And we engaged the help of Health Watch to help us really and meaningfully engage with our populations to see, one, the survey that was done in 2017 and what the richness of the feedback was and how we could continue to engage and get those views. So the feedback that we've had and what we've seen has helped us to create models of care and proof of concept really that we have piloted over the last 12 months. And they fit into four key principles. And they're around reducing unnecessary referrals. So this isn't around saying that we want to reduce the demand. It's around how can we reduce patients having to come to hospital unnecessarily by better triage of referrals and making sure that people see the right clinician the first time. And it's around advice and guidance to GPs and around enabling conversations between GPs and clinical colleagues within the trust that maybe can help patients be looked after at home and prevent them having to come to hospital. Another principle is reducing the number of appointments, looking at how we can provide diagnostics and consultation on the same day in a one-stop shop type of model to prevent multiple visits for a scan, an X-ray, a blood test, and then to come back to be told your results and have that consultation. And increasing the use of technology. As you know, CHFT is one of the national leaders in our digital readiness, and we wanted to build on the use of the technology that we had to create different models of care through telephone consultations, through video calls, to enabling multi-professionals to talk to each other and discuss cases virtually. And it's about delivering care in the most appropriate setting, and that's not always a hospital. That's sometimes a community setting, it's sometimes a primary care setting, and it's sometimes in the patient's home. This is just a snapshot of a point in time of the pilots that we've had ongoing. At the moment, we have over 40 schemes that we are working on at the moment, and as you can see, they fit into the different categories. Within the paper that we have provided you with gives you some examples of the models that we have piloted over the last 12 months, such as a cardiac arrhythmia clinic, one-stop cancer prostate clinic, straight to test for colorectal cancer, and the gastroenterology clinical assessment service that ensures that patients go on the right pathway. We've done a lot of work in ophthalmology, and we've done a lot of work on how we can best use our technology that meets with patients and their needs, and how we can communicate and educate people with that. So 1 year into the programme, where are we? One of the things that we're really proud of is that we've created a system-wide governance group. And where this has been introduced as the Calderdale and Huddersfield programme, we don't regard this as the Trust programme. This is a service-wide initiative, and my colleague Debbie is here today, sharing her experience with you. We have an oversight group, a governance group, which consists of senior members of the Trust, clinical team, our clinical directors, involved clinicians, our divisional directors. It's chaired by our Director of Transformation. We have the project team, and then alongside that we have the local medical committee represented, we have Health Watch, patient representative, we have CCG governing body members, the GP federations, and any interested party, to be honest, that wants to come forward and has a real interest and a passion with this. And we discuss the models, we discuss the pilots, the proof of concept, how they can be adapted, and the patient evaluations at each monthly meeting. We've developed a portfolio of concepts. So each of our schemes has been piloted, it's been evaluated, it's been adapted. And one of the principles that we have is that schemes can be replicated in other areas. And our clinicians come and talk about that and share their experience. In last year, in our first year, 2018-19, we impacted on 8,000 patient appointments. Now, that's not reduced 8,000 appointments. That's about 8,000 patients being offered a different pathway. Now that might have been that they were triaged by telephone, it might be that they've gone to one-stop shop, or it might be that they have not had to come into hospital at all. We have plans in place this year looking at the proof of concepts and the models that we have to expand that to 26,000, and we're aiming for a 34,000 target this year. Because what we've set the challenge internally is, let's see if we can impact on 10% this year. What this has done is this has allowed us to enable other uses of resources. So we've got surgeons going into theatres, we're reducing our waiting times, we've reduced our lists, we've reduced the number of appointment issues that we have by reinvesting some of the resources that this has released. We've had some strong clinical buy-in, but we've also realised that we need to re-engage our patient survey again. So where the patient survey was done by Health Watch in 2017, we've just undertaken another exercise during August to resurvey our patients and worked with Health Watch and the CCGs to do this. And we've had, in a 2-week period, we've had 1,500 responses. The results are pretty much the same and in line with what the original Health Watch said. And what it's saying is that while patients are still want the option of having a face-to-face appointment, 90% of them said that they would like to be offered an alternative, telephone consultation being the most popular one. But what this is enabling us to do is to look at where we need to focus and work with people to see how we can maximise those opportunities and make it work for people. We've also engaged the help of Health Watch to work with more hard-to-reach groups and groups of people with protected characteristics. And a piece of work that's ongoing at the moment is working with groups, and they visited over 20 groups at the moment to look at how our principles can be adapted, so such as the use of telephone, the use of video consultations, how these can be adapted, what kind of reasonable adaptations we need to make them work for people. And we've been quite astounded with the results. So far, the early figures that are coming back, 50% of people have said, actually, we can do this without any help or adaptation. And about 45% have said, with a bit of help, if we got it right, as in the timing, and we had a carer here or some additional support, we could do this. As I said, that's still ongoing, but we want to make sure that this is an inclusive and equitable offer for all our population. We're sharing our experience. We've been talking to other organisations and sharing our learning. We presented at an NHSI conference in November last year, again to share our learning and gain learning from other organisations and link up nationally to do that. And the programme has been shortlisted for a Health Service Journal Award in the acute category for redesign. I'm happy to take any questions.
Thank you for that. Any questions? Councillor Munro.
Hello, I'm Councillor Alison Munro. It's just in relation to your new models of care and avoiding unnecessary referrals. You've got a new system with the tick review of choose and book referrals for cardiology. Now, I've recently come across a case where in actual fact there are no appointments on the system. Now, this is concerning a lady who's kind of middle-aged, and she of this person couldn't there were no appointments available, and so they put some comments in a box. Now, she's not au fait with computers, waited a few weeks, nothing came back to her. So because she's not computer savvy, she didn't know what to do. So in actual fact, there's been a delay. Then she's gone back to a GP. She could actually speak to a GP. She phoned up and they said, well, you've got to go back on the system. So now she needs my help to enable this to happen. And she doesn't want to travel very far. So this system, it's not working. And you claim the project has removed the need for unnecessary appointments through new outpatient models, but the problem is there are no appointments. So how is this available? So,
following on from what Councillor Munro said, what about people that have language difficulties or don't read English? How do you sort of engage with them through this model?
I'll respond to your question first. Whilst I can't talk about any individual case, what I can talk about is the principles, and I'd be happy to take that case forward if you wanted to give me the details. The triage that we're talking about on here isn't the choose and book system, but what it does, it supports a choose and book system. So where we know that we've got a problem in cardiology with the number of appointments available, the work that we've been doing has been twofold on cardiology. So we've set up a one-stop shop for the arrhythmia clinic, which reduces the number of appointments for arrhythmia by enabling the diagnostics and the consultation in the same day. And that's a separate pathway. The cardiology appointment, what we've taken is from the learning from the gastroenterology triage system that we've put in, which has seen us release a significant number of, bring our waiting list down significantly. We are now implementing that into cardiology, which means that each of the referrals will be reviewed, and then if it's appropriate to send that patient straight to a test, they will be sent straight to a test. If it's appropriate to put them in a subspecialty clinic, they will go and see the right person at the right time. What this will do by doing that is it will reduce the number of unnecessary appointments, such as patients going to see a cardiologist that subspecialises in one specialty and then having to see another one, or removing the need for them to be seen first, to be told you need to come back for a diagnostic. So that's they can have the diagnostic straight away, so that when they sit down with the cardiologist, they have a meaningful discussion. So that is helping us free up some capacity to bring that waiting list down and create more appointment slots. When we're talking about reducing the number of appointments, we're talking about for that patient, not the capacity that we have in the system.
But so could you just explain why this person has difficulty using the computer and understanding that why they didn't get a response to the question that the message that they thought they'd sent you, so people are going to really literally fall through the net because unless they phone their local counsellor up or somebody who can help them, how are they going? There's been an unnecessary delay for this person. through no fault of her own, and and she thought it was her, and in actual fact, it's the system that's not working properly. So it really needs more input on the online, operating the online system for people who don't have, who have basic computer skills, but perhaps don't fully understand how computer systems work and messages that they put on them.
Right, can I just following on from the same point here? On the plus note, I had an experience of the one-stop thing, chest pains, I was amazed. The whole thing, scanned, in a day, brilliant, within 3 hours. On the negative, I'm very much in that middle road of computers. And I know many people, I come across them all the time in the council, who are struggling with computers and a whole range of issues. Would it not be possible that, as far as the doctor's concerned, at their basic, there is a question on, do you use mobile? Are you able to receive appointments? Because, I once tried 3 times exactly the same situation. You've got to go back, and I had to go back, and this was just for routine checks. So there's clearly an issue with the ageing population who weren't brought up with computers, which is basically those of us 50 plus, where this drive to technology, which I know is award-winning and is fantastic if you can operate it. So is that an area that is being addressed?
So in the engagement that we've done, that has come across as one of the messages. So we've been working with the private sector businesses to say, how have you done this in the past? How have you moved with your customers? So if online banking, such as supermarkets that have gone to online shopping. So we've been trying to find out from industry how they have worked with customers to say, to move forward with them and do the education. And what we are putting into each of our outpatient sites from, it will hopefully start in October, are some digital hubs. So as patients are coming in to hospital, there will be an area available within the reception where we'll be asking patients if they want some help with the use of technology. And what we'll have there is, it won't be your latest kind of Mac computer or anything like that. We'll have a selection of Android phones, iPhones, a 4-year-old computer, average of what we think will be in people's houses for them to use, and say, okay, so what would you be using at home? Can we talk you through how it would be used? And to try to help people that way and get used to them. And we'll have volunteers walking around the outpatient departments promoting this to people. And of course, what we're not saying is everyone has to use that. We're saying this is an option for people. Now, the primary care side of it, when we can do that once they're in the system, from the primary care side where they're making an appointment. I don't know whether, Debbie, you want to comment on that?
The idea, our general practices, their ambition is that a person walks away with an appointment, so that there isn't the scenario that we talked about. They understand that actually there is quite a lot of training education needed, both in general practice and also working with their patients in, say, groups. Patients perhaps who access dermatology services who can get support in a different way. So I think across the board, the aim of clinicians at all levels is to try and reduce the number of patients that come to hospital and could receive care in a different way, but also to make sure that those patients who are of an age or have a tendency not to like IT solutions can actually use the practice as a way of interfacing with the hospital. We're not trying to make it harder, but I think there's a natural, as we move towards more IT solutions, these kind of problems do emerge, and I think both in our practices and obviously in the hospital we're trying to address those as much as possible.
Okay, thank you for that. But my question still remains that the link between the primary care, between the doctor, going to see the doctor, I have not yet experienced or seen any evidence that you are asked about your technological ability, that there is not an option that's, you're told everything's coming by mobile phone. But certainly there are community groups having been involved within Slough when some people still don't have a mobile phone. So that's the first thing. The second thing is that this system of waiting and then having to make a phone call, for some people is just too puzzling. Now, is the doctor, are the primary cares, are they able to log that there are still going to be people at risk who aren't being able to fully access the support services they need?
I don't know whether there's something that's systematic, but actually that's something we could definitely take back, because GPs don't want a scenario where patients are receiving information about appointments and then either not going because they don't know or not able to change them because they can't route themselves through a complex system. That's something that really happy to take back. We have groups of champions that work in general practice. So each general practice has a patient reference group. And that's something that each practice is mandated to have, as you'll be aware. Those practice reference groups are there for exactly this reason, to understand, and they tend to be people perhaps that are over 50. That would be something we could ask the patient reference groups if they could look at for each of the, and all the patient reference groups then come together in a kind of a larger group. So I think that's something we could definitely take back and then report back on in terms of progress, because I think it's a very
Thank you. I think that would be helpful.
Linkida, good morning. I'm a co-optee on the panel. I just want to talk about a scenario where a patient, for example, has been to hospital for an outpatient appointment. The clinician needs to see them again in a few months' time, but there aren't any actual appointments available at that point, so the appointment is going to come out later. And then in due course, the patient gets a text on their mobile phone advising them that there is a digital appointment that they now need to access, using a PIN number that's provided within the text and their date of birth. But in order to do that, they have to click the link on their phone. Now, the text comes from an 0700 number, which the person doesn't identify with as one of their contacts. So it's a random number that could be a scam number, for example, and click on that link and gosh, who have you given access to? All the stuff on your phone. It doesn't actually tell the person within that text that if they don't open that link and view the appointment within 48 hours, they will get an appointment letter sent out in the post automatically, and that digital appointment will disappear in effect. Now, if the person were able to look online, there is quite extensive guidance on there about digital appointments, which does cover the bit about if you don't open it within 48 hours, you'll get a letter. But the person doesn't know that when they get that text. And bearing in mind that we're all aware that if we don't attend appointments, we can be discharged back to our GP. The person is particularly an older person who perhaps only uses their phone for emergency telephone calls, maybe not even for texts, but you know, if they do when they've viewed it, can become very anxious waiting for someone to come along, maybe at the weekend, to help them to look at, you know, and to actually realise they're not going to be able to access it on their phone because it's not set up for the internet. And actually, this seems to happen automatically as long as your mobile number is recorded in the hospital records. And it's not a case of being asked, do you want to opt into this process? It seems to be imposed. And furthermore, if a patient asks to opt out of it, they're not able to at the moment. And so the only way really to opt out is to ask for your mobile telephone number to be removed from the hospital records. But then that would impede the text to remind you of your appointment, which I think is good all round for the patient and the service. And I just want to ask, what's happened to patient choice in that regard? You know, if I understand about, you know, we want to try and drive forward digital access and all that entails, but I think we do have to accept that some people choose not to go down that route. And I think that choice should be respected. And just to be told, well, no, you can't opt out, I feel it's unacceptable, to be honest. And I'm particularly concerned, as I say, about this random mobile number that is a cause for concern. And just to save me coming back later, if an appointment that is given isn't convenient, when you phone up to try and change it, it's not always possible to do so because there aren't any appointments available for the future period by that time. So the patient is advised that they will go on a waiting list and be contacted when another block of a block of appointments are released. And they do in due course get a further appointment, but it's another random one that they've not been involved in arranging. And sometimes that might not be convenient for a variety of reasons, including the person might be a carer and has to make special arrangements to cover their caring role in their absence. And so that's another concern for me in relation to choose and book, because you're not really being given the choice about when you can book. And that's not very good customer service. And I think my final point is that on occasions when I've attended outpatients in recent months at Huddersfield Royal Infirmary, I have been quite concerned to notice the significant delay in the running of the clinics, advising, a 55-minute delay or whatever. And some of the patients attending, again, are older people who really struggle to just sit there and wait all that time. And so, I suppose what I'm saying is, I like to see that things are changing and we're looking at new ways, but I'm just a plea from me not to lose sight of the basics while we're ploughing ahead with all the new stuff, please.
Yeah, just on your last point, if I can take that one first, absolutely agree with you. That's why we're doing this work, because it is unacceptable that those clinics are overrunning and there are such delays. And that comes back to what I was saying in my presentation. Our service is unsustainable at the moment. We don't have the capacity to deliver what the growing demand is. So this is why we're trying to do things differently to make that better. We are aware that there are appointment issues, and again, that's why we've put some things in such as the triage and the straight to test, and we're trying to create that capacity, because this is how we can do it. By doing some of these new pathways, we are then releasing that time to get those additional appointments into the system so that patients are not having to wait, because that is unacceptable. And as Debbie said, you should be walking away from a GP with your appointment. You should be coming to clinic and walking away with your next appointment. And I fully believe that the appointment should be available when it's convenient for you, not when there's an ad hoc cancellation or when it doesn't work for you. And that's our ambition with this programme. That's what we want to create. We know the basics are not perfect at the moment. We are aware of some of the technical issues with the choose and book system, and we're looking at how we can get round that and how we can work with the national systems that we've got. Because some of this with choose and book, it's national systems, not our local systems, but we're trying to see how we can adapt those to make them work and make that work for patients. We're not there yet. We've been in this programme for a year now, so we've got a long way to go. As I said, some of the initiatives that we're doing are still in pilot form, but we're hoping that that will help resolve some of these issues. And I can assure you we do have our eye on the basics, because that's what we're trying to resolve at the same time. But we've got to look at how we can release that capacity to get that front end right.
It does, but just to go back to the point I raised initially about the text messages and the random mobile number and the inability to opt out of the digital appointments if a person wishes to do so, I would like to ask that steps be taken to deal with that urgently, because of the distress that it does cause patients, and in particular older patients. I can't stress enough the anxiety that creates for people.
Absolutely, and I will take that one back. We'll take that as an action. I can't give you an answer now on what we can do because I don't know that system. But what I will do is I will take that back to the team that deal with that and feed that back as an urgent action.
I think the only final point I would make about that is that the text doesn't have a contact number in to ring in the event of any queries or concerns, and if it had, that might help, because as long as someone answers that phone and someone isn't just hanging on for a very long time, it just seems as if it's determined to get you down the route of the digital appointment regardless of your personal wishes. And I think we've got to look at the holistic view, really, haven't we? And just think to put yourself in the shoes of the patient and think, now, if I receive that text, what would I think if I was 85 years old and, you know, couldn't see very well, and I don't have a computer, or, you know, my phone is not set up for internet access. Thank you.
Thank you for that, Peter.
Thank you. Thank you, Chair. Two things, please. One, unnecessary referral. And then secondly, rapid access. But to take the first one first, please. I just wondered what you were doing about the unnecessary referral issue with the GPs, given that there's a tension between unnecessarily sending somebody to see you, which of course empties the surgery and converts the GP's problem into yours, for that to happen, or for the GP to hold off and do other things and risk delay. And in particular, it brings up the international cancer benchmarking figures of last week that show that delay is probably a big feature in why we're lagging behind most highly developed countries. So I just wondered how you were dealing with referral behaviour, please.
Okay, so you're absolutely right. So the demand varies. The variation in demand across practices can't be simply because of need and demography. We know that because actually practices, and that reducing that variation is something that we've strived to do as part of this programme. So both CCGs invested last year in a referral support system. The system works with both System 1 and EMIS practices, so it covers in Greater Huddersfield and Calderdale, all the practices. And it's actually been installed in, I think, 98% of practices. We're just doing the last two at the moment. This is a template-generated system, so when a GP goes into their clinical system to do, say, a dermatology referral, the first thing that would appear as part of the template would be some education and advice about if this is, say, psoriasis or eczema. There may be other things that could be done by the GP, and the starting point is is that intervention, and whether this is indeed something that could be done within the practice or a community pharmacy. When it comes to a point where the GP recognises that he's exhausted those steps, or those steps are appropriate in the case of the patient, there is a template-driven referral then generated, and all the questions that are in that template use NICE guidance to generate the referral. So in a way, the GP has to assure the template that actually any test results have been done, that conversations have been had with, and interventions that are in the early stages of the pathways have all been completed. And then the referral will go automatically then to the acute trust. What we know is for dermatology and ophthalmology, there is still a need for those referrals to be triaged to make sure. In ophthalmology, there are a whole range of different clinic types, from cataracts to glaucoma to macular, and so that referral referral helps to determine that triage. getting the patient into the right clinic at the right time. The system, the referral support system, not only is being used in every practice in Calderdale bar, the two that we're working on, but actually all the future pathways and the templates that are being generated have been put onto this system. There's a big appetite in general practice to do this. I think also things like in ophthalmology, so we have a couple of services in ophthalmology, so the vast majority, I'm thinking probably about 75% of high street optometrists in Kirtlees and Calderdale are part of two services. One is a referral refinement scheme, so if someone's going into their high street optician with a query about their eye care, say that's a referral, they think they may need a referral for cataract, the optician will refine that referral using nice guidance to ensure that actually the referral's been made at the right point and not too early. And also that any care that can be provided by the high street optometrist is provided at that point. They also provide an acute eye care scheme so that if you have a foreign object in your eye, instead of going to A&E, and we have a lot of people going to A&E for foreign objects, that actually the high street optometrist will also provide that service. So I think our GPs recognise they need some support with their referrals, and that's now in place. We get into the stage in, I think towards the end of September, we'll have the first performance report that will talk about not just which GPs are going into the system, but who are going into it regularly and using it to support their referrals. So that will be part of, but also the other options that we're trying to create in the community.
Sorry, can I just, I mean, presumably, you know, if a GP says, and I'm thinking about the enforcement of all this, if a GP says, look, I've got a round of golf at 11 o'clock and I know you need to see somebody, and chooses not to use the algorithm, what do you do about it? Because you can't control their wallets.
So the most of it, our GPs, I don't know any of our GPs play golf. There may be some. I think it's our GPs. I know it was. Our GPs work incredibly hard. I don't believe, you know, and I spent time with a lot of them, and they want to do the best for the patients. And actually, the more templates we put into that system, the more it becomes very difficult, because if a GP does refer something through a different route and it's a poor referral, it'll go to triage and the letter back. And what we're encouraging our clinicians, the clinicians in CHFT to do, is to be very clear, this is not a good referral, these are the interventions you could provide for that patient closer to their home and in primary care and much quicker than them having to wait for an appointment with a hospital clinician. So I think our GPs there is more of an appetite for us to help them, for them to help the patients. And the GPs that are a bit more reluctant, will be putting some great deal of encouragement in there. So we have super users for and champions for these new systems that are going into each practice. There's also a lot of education going into all the practices. So our intention is to get there, albeit it won't be straightforward from day one.
Just an aside, because I think you made reference to it. Do GPs still exist?
Yes, so GPs with special interest do. So in Calderdale and Greater Huddersfield, those GPSI, particularly for dermatology, are being used to support a community offer for dermatology. It's that balance between, you know, encouraging our GPs to be in their practices when patients need care, and also encouraging them to be specialists in some things that will support the whole of their practice, or indeed the whole of the practices within their locality, so that if there's a GPSI for dermatology, then it helps all the practices in each of the new primary care networks rather than just its own practice.
And just come to the bigger print stuff, the whole business of straight to test, and just where that's going. I say this in the light of the cancer report last week.
So on the straight test, our colorectal pathway at the moment, so our 2-week waits, we've trialled it on, colorectal 2-week waits for cancer. are going to our straight to test. It's like a rapid assessment service where we have the referrals will come in. They will be reviewed by a physician's assistant or by a nurse specialist, and they will be compared against a pathway and the criteria, depending on what criteria they need. If it's a case of that is just an obvious, they need to go straight for an examination, then the patient's given the appointment. If it's that it's obvious they need a consultation with a clinician straight away, then it will be. But the physician's assistant or the nurse specialist contacts the patient and discusses all the options, all the pathways, gets a little bit more history from them than what's on that piece of paper that's come from the GP, to get a full picture from that patient about what's been going on, and then they are put straight through to their test or straight through to their consultation. And we found that that has speeded up our colorectal diagnostic pathway. We've put in for prostate cancer, we've trialled a prostate one-stop shop. So patients will be triaged. It will be a paper triage to say, a 2-week wait, let's put them straight through to this one-stop shop, and they'll go and they'll have the diagnostics and the consultation on the same day. It means that they get an MDT assessment really quickly, and when they sit down with that consultant, they can have an informed discussion where their results are there and the patient knows what's going on. And we found that within prostate, it reduced some people's pathways by 50%.
And plans for anything else?
We are rolling this out. Breast already do a rapid access one. With the colorectal one, we are looking at upper GI because it's the same people, so they're trying to adapt that. We've put more resources into the colorectal one. In cardiology, we're looking at the rapid access. They're adapting it. We've put one into gastroenterology. And we're looking at where that can go next, because what we wanted to do was get the model right rather than just saying, actually, we've put it there, it's worked, let's go and put it in somewhere else. It isn't a case of one size fits all, so it's then a case of looking at it, evaluating it and seeing how you can adapt that. But absolutely, we've found that this is the way forward with them.
Thank you for that. Can we consider the information that's being presented before us? And I have 2 recommendations. Review the appointment system urgently with option to opt in, taking into consideration patient choice, and improve communication with patients who are not able to fully access the information they need, i.e. those who don't have a mobile phone or a computer savvy or may have language difficulties. Is there any further? Okay, thank you very much for attending. Okay, can we move on to the next agenda item? Can we move on to the next agenda item, which is the programme of work for the scrutiny panel? You have before us a paper which indicates the work plan so far. Are people okay with that? Do we have any comments? So the next meeting will be held on the 15th of October, where we'll be discussing the winter planning and FASD update.
Chair, would it be possible to have a further session that isn't a workshop on PCN, primary care networks? Where, you know, because I think a lot of us are quite unclear about what's happening in, you know, in specific areas, and And if there is any impact on sharing of services, so sort of early next year, you know, when the winter's out of the way, could we just look at PCNs again?
We can have that on one of the future agendas. If there is no further comments, if we move on to the date of the next meeting, which is 15th of October. Thank you very much for your attendance, and the meeting is now closed.
Thank you.